Can you guys hear me okay? Is that a yes? All right, cool. Good. All right. All right, so good afternoon, everyone. My name is Alex. I'll be presenting our QI project on reducing missed therapy minutes in acute rehab. Today, I'll be going through a brief overview of admission requirements, define missed minutes and their implications, highlight articles supporting our data, go over our baseline data analysis and results, and then go over our proposed interventions. All of this hopefully within the next 10-15 minutes. As most of you know, there are specific CMS guidelines for acute inpatient rehab admission, but we were focusing specifically on the patient requirement to complete 3 hours per day, 5 days per week, or 15 hours over 7 days. The 15-hour rule usually ends up applying towards patients that are a little bit more medically complex and requiring more testing throughout the course of their acute rehab. So sometimes we have to implement that. Now, what are considered missed minutes? Well, according to our rehab policies, missed minutes end up being any time that's missed greater or equal to 15 minutes. And that results to be about 1 therapy session missed. These missed sessions will need to be made up in order for the patients to qualify for their stay. And this evidently always leads to delayed rehab progression. Out of rehab will increase your length of stay and cost. And in general, it often translates to poor prognosis for the patients. It's important not to delay or interrupt our therapy as much as possible when we do rounds, so we have to be cognizant of that. In an ideal world, no ACIR patient misses a minute. However, in the reality of things, patients do miss minutes for a multitude of reasons. And a significant number of our patients who are missing minutes can be classified as suboptimal ACIR candidates. There are many reasons for missing minutes, and they are typically documented by our therapists on the dashboard. And there's about 15 or 20 reasons that can be documented, and they include medical hold, illness, pain, testing, refusal, nursing care and scheduling conflicts, as well as fatigue and just the effects of appointments and discharge. Oh, sorry. Okay. So what does the literature say? Paul and Slade conducted a randomized single-blinded trial in the UK of neuro-rehab patients, and they randomized them into 2 arms, low intensity and high intensity. And this was actually very surprising because their high intensity was only 1 hour and 15 minutes per day. And not shown on these slides, but their length of stay was about 80 days. So that's way longer than what we normally do here in the US. But they did show that completing the 1 hour and 15 minutes per day did result in a shorter length of stay, which was significant, as well as lower costs for the hospital itself. And if you extrapolate this to us, I mean, if we're doing 3 hours per day, we're definitely trying to reduce the length of stay and get our patients home as quickly as possible. Another study by Ditchkers studied 6 inpatient rehab spinal cord units, and they basically found that there was more reasons for missing therapy due to medical factors. The writers attribute this to suboptimal timing of transition and basically stating that the patients just weren't ready for rehab. And another study that we really kind of basically end up basing a lot of our interventions on would be Hammond et al. As well, who identified logistical and medical reasons as the primary cause of missed minutes. And they proposed strategies including streamlining their scheduling diagnostics, improved medical screening before admission, as well as increasing the amount of staff in the morning to get the patients ready for their rehab of the day. And not mentioned on the slide itself, but I think it's important to note, there was an article by Feacham in 2002 who compared California nonprofit institutions and the UK, and they concluded that hospital bed days are the most expensive component of the health care system. So as we reduce the length of stay, we reduce cost, which is great for everybody. So now this brings us to the goal of our QI project, and that was to assess how many of our patients were missing minutes and why, and identify any possible subsets of at-risk patients. And finally, obviously with a QI project, we want to make sure we can develop something meaningful and measurable in order to intervene and see a reduction in our missed therapy minutes. Our baseline data was done through a chart review of 290 patients discharged from Meyer 7 over 6 months from April 1st through September 30th, 2018. We did so by going onto the Epic dashboard, and you can pull reports of the per patient and how many minutes they missed, as well as the reasons for this. This was possible because therapists are being pretty diligent about logging their missed reasons. We then stratified these patients by age, gender, diagnosis, harping on medical, oncology, or surgical diagnoses, length of stay, total number of missed minutes. We used a ratio to actually be able to kind of equate this throughout, as well as each specific reason and eventual disposition, just to see where our patients were going and see if there was any kind of correlation. To simplify things, we chose 4 broad categories, and we categorized our patients into medical, logistical, activity tolerance, and behavioral reasons for missing minutes. And this is our preliminary data. As you can see, their diagnosis and the age were not significant predictors of our missed minutes to length of stay ratio. But we did notice that patients were significantly more likely to miss visits due to medical or logistical reasons. And this was actually very interesting because it was correlating with Hammond's study and gave us more validity. And we also noticed that significantly more patients without missed minutes went home, which seems like this is kind of common sense, but at the same time it's good to see it with some numbers. So what did we learn? All patients, regardless of age or diagnosis, are at risk for missing minutes, and that's true. Medical and logistical factors are the most common reasons for missing minutes, and patients who miss 0 minutes are more likely to go home after acute rehab. The secondary findings were a little bit more, I guess not obvious, but anybody with the missed minutes per length of stay ratio was best predicted by the number of medical, activity tolerance, and behavioral reasons for missed minutes. So really the logistical reasons weren't actually contributing as much as we thought it would, because that was one of our initial hypotheses. If you've been on our unit, typically patients with like radiation therapy or appointments, you would think that they would be getting less time with their therapies because of it. However, there was no difference in missed minutes per length of stay among reasons for missed visits, and likelihood of going home decreased if patients had a surgical diagnosis or missed visits due to medical reasons. So for our proposed interventions to reduce these missed minutes, we... So
what is logistical reasons?
So logistical reasons would be like appointments, radiation therapy, nursing issues. If there was, for some reason, the patient wasn't ready for therapy, like say they didn't eat their breakfast, that would be considered as a logistical reason. We actually categorized nursing care under medical, but it was more stuff that like just getting the patient to the therapy room and getting them doing their time with the therapist. So using the Hammond study as our backbone, we were trying to do the same thing. We would like to streamline our logistics. One thing that they suggested was to have more staff in the AM to get the patients ready for their therapies. This is a difficult thing to do because the number of staff is a limiting factor. So if you don't have the staff, it's kind of hard to implement. But the one thing we did immediately was to improve our communication amongst our acute rehab team. And we've done this with having nursing, we call them check-ins, but they're basically like a little sign out in the morning and at PM in order to bridge the communication gaps and make sure that there's no loss of care for the patients. We also wanted to improve our medical screening to reduce the suboptimal admissions by improving this. In order to do so, we figured the best way to kind of tackle this matter was to update our harmonized consultation note. Because when we were reviewing it, there's areas where we can update or even modify in order to help our rotating consultants tell the difference between a good candidate and a poor candidate, especially since different institutions kind of have different admission requirements. And this would identify patient-specific barriers to therapy, and this will give our admitting team a better preparation for what they're to expect out of the patient. Our new harmonized consult note template is being created and edited currently with our help from our EPIC informatics coordinators in collaboration with several attendings and administrators, and it will be tested on real patients by the end of April, and we will hopefully be live in May. You guys have any questions?
Alex,
Yep.
the diagnostic groups you chose are a little unusual in terms of how things are usually categorized in rehab. And I'm curious why you use like UBS or things as opposed to medical, surgical, and oncology.
So this was because when we were initially in our early time for the QI project itself, there was a list, an unofficial list that we have that Stacy actually brought up from the therapist, and just kind of to see like dating back of like suboptimal patients and who was kind of what kind of diagnoses were these patients associated with, in order to that we're hoping like to see if there was any prediction which patients were suboptimal candidates. And at first we actually thought the oncological patients would be the ones that we would see in the data to be the ones that had the most missed minutes over length of stay, specifically the ones that were getting radiation therapy. And that was actually one of the things that we modified pretty quickly, is to try to get the radiation therapy back on track so that it's not interrupting our therapies. And that's why we stratified them to medical. But medical really captures about anybody who had a stroke will fall into medical, anybody who had like pneumonia with debility, critical illness, myopathy, or any kind of prolonged hospital stay that wasn't really falling into a surgical or oncological diagnosis. We actually, with the help of Ryan, decided that the best way to go about this is actually to tally up patients who met all three categories to see if there was any kind of difference between that, and that was actually how we got our data, because we did notice that a lot of patients were both medical and surgical or even oncological patients. So we tried to see if they're labeling everybody as all three, if there was any difference, for example. But a lot of our stroke patients, they just fell right into medical. Surgical patients, like somebody who had a spine surgery, that was considered just a surgical diagnosis. Transplant patient, we placed as, depending on why they had the transplant, we would either categorize them as surgical and medical. So they would get like a tally for both, because they had complex medical needs. Yes?
It's a very nice project and very well done. So you might think about expanding this, right? Because you're thinking about missed minutes being related to length of stay on rehab, right?
Mm-hmm.
You're on the front end, you're saying is, well, we just pick patients more carefully so we have fewer patients with mixed minutes, right? But I really don't care how long they stay on rehab. What I care about is how long they're in the hospital altogether. So you can improve the missed minutes, by keeping them off rehab unless they're prime, ready to go, which means they're sitting on acute care longer.
Right.
Right?
Right.
So, I mean, I think this is a great project. It begins to think about how when you squeeze it in one place, you move it somewhere else. And from the health system perspective, I don't really care whether they're sitting on acute care or rehab, they're in the hospital. Right?
Mm-hmm.
So it's interesting when we can look at this as you've done very nicely about how it affects rehab, but the way to solve our problem is to move that problem onto somebody else, right? That is tighten our admission criteria, right? Which means, so it just, I think it's a very nice piece of work, but we need to be, I think there's opportunity to expand this to say, what happens when we do get a better harmonized note, which is going to cause us to be more selective, and how does that impact upstream methods?
So we were actually kind of brainstorming this as well, because we were trying to figure out where would like our shortcomings be, and we were hopeful. I mean, once the harmonized note is out and about, whether or not we can actually see any other kind of patterns with the new note regarding with the questions that we're asking our patients, the questions we're asking the teams, can we somehow make a scale or a score in order to actually even see if a patient would be suboptimal? And in that case, it wouldn't be that we would keep them on the acute service. It would be more of like an indication, hey, this patient should be going to SAR from the get-go, because I mean, in my opinion, if somebody is coming into acute rehab, our main goal is to get them home. But if somebody was destined for SAR, is there really, how much benefit is there for a patient coming to our unit before they go to the subacute?
The right person in the right environment.
Correct.
And can I also just say, to address that point, that we don't want the harmonized note to increase our declines for admissions. We just want to better prepare the ACIS team for potential barriers or patient-specific risk factors for decompensation or medical instability. And so we have specific questions like, what other workup needs to be done for this patient? Is there anything pending? What are the cognitive barriers? What are the psychosocial barriers? So not saying no to people who aren't perfect rehab candidates, but at least better preparing the team to overcome those barriers when they do come.
Question.
Yep.
Question. Do you control, so clearly you showed that missing minutes have less likelihood to go home or longer than stay.
Mm-hmm.
Do you control for severity of those patients? Is it possible that people who are missing minutes are the ones who have more severe conditions, more complex conditions, and then they are missing minutes because nursing takes longer to get them ready to go to the gym? Or
We would have to go.
how do you control for something like that? There's something called CMI.
Mm-hmm.
I don't know if that.
Well, those kind of patients would probably have fallen into our medical or logistical categories, because it would have been, for example, for medical reasons for missed minutes, it would be patient was ill, they're undergoing testing, or some kind of medical complexity. So they would have fallen into that category when we were doing our ratios, and so they would have been, probably, you're right, they might be skewing the data and showing that people that are definitely sicker are probably staying longer. Not sure that the best way to rectify that at this moment.
We have control for that in some statistics, so that's consideration.
Mm-hmm.
But I agree otherwise with what Steve was, Dr. Wegener was commenting, that it would be interesting to then take this even earlier, where the acute consult service measure something about efficiencies when they show up to see a patient in the regular bedroom, and then they cannot see the patient for whatever reason.
Right.
And that also is another form of missed minutes, let's say, or inefficiencies in the system. And that would be interesting to start matching what is observed in the acute medical unit with what's going on in the rehab in terms of similar metrics.
That is definitely a good idea. I think Nick had a question. No? Okay. Thank you.
We have, for our featured speech today, Dr. Jonathan Weinson. Thank you so much for coming from NYU. He's the Director of Cardiac and Pulmonary Rehab at Russ. He did his PM&R training at NYU. He's done cardiac and pulmonary fellowship training. He's well published, and I think he's even been on some radio shows and some news programs. So we kind of have a celebrity on our hands. Let's just pull up your talk, and we'll let you take it away.
Okay, I'll use that laser pointer a little later. Thank you for inviting me. I really appreciate being here. It was a wonderful trip down from New York City this morning. I'm going to be talking to you about aerobic exercise at the core of rehabilitation medicine, the path to follow. You may have seen this path. You know this path? The yellow brick road. I don't know how I got onto The Wizard of Oz, but it plays a theme in this talk. So I have one disclosure as a consultant to Nestle, absolutely no relevance to this talk whatsoever. These are my objectives: to understand the connection between physical inactivity, disease, and disability, appreciate physical activity guidelines and the reason we don't achieve them, understand the model of fatigue in disability, discuss the evolution of aerobic exercise as medicine as an impact on disease, disability, health, and longevity, understand and apply the cardiac rehab model of aerobic exercise as medicine in cancer, brain injury, and stroke rehabilitation, and discuss a future state of rehabilitation medicine based on aerobic exercise. The bottom line is, I think what I want to do is implant in you a seed of thought about aerobic exercise. And perhaps we can completely restructure this whole field of PM&R all around aerobic exercise. Wow, that's very lofty. And I'm not saying that that's what you're going to do, but I just want you to think about it for the next hour. I will apologize. I'm going to have to speak fast at times and jump through slides quickly because I think I have 144 slides. Forgive me. I thought I was given 2.5 hours. That's a joke. Okay. This is not rocket science. We're not going to put a person on the moon or on Mars, and the path may be a little convoluted, just like this space rocket here. Maybe it's a little bit like ducks to water, because the first thing that we do when we start to become mobile is get up and walk as, 8, 9, 10, 11, 12, 13, 14-month-old kids. We know how to walk and get around, so really we're going back to the duck to water phase. And this is Mr. Magoo. I'm sure you all know Mr. Magoo, but if he can see the benefit of exercise, then we should be able to as well. Houston, we have a problem. I grew up saying this phase. I was always interested in space and whatever, but actually it was, okay, Houston, we've had a problem here. It was Apollo 13 astronaut John Jack Swigert. Did you know that phrase? Did you say, Houston, we have a problem? I grew up saying it. Anyway, Baltimore, maybe we have a problem. This is our problem, is that too many people are dying from these diseases. These top diseases make up about 60 to 70% of the reasons why we die: heart disease, cancer, chronic lung disease, unintentional injuries from behaviors and things that lead to those poor behaviors, and stroke. So we need to do something about this. We need to understand what we can do to make a difference there to all those ailments that kill us. It's not just that they kill us, but we live with these diseases and disorders as well. 50% of our adult population is living with at least one chronic disease, and a significant number are living with at least 2 chronic diseases. And it ain't cheap. Who is it? Dr. Evil, when he says $1 million, with nearly $3 trillion in annual healthcare expenditures in this country. You can make the world spin faster with that amount of money, but it's all related to the amount of chronic disease that, we develop. And you can see, I think that's about a third of our population, or a third of the expense. It comes from people who have 5 or more chronic diseases. And as I say, it's not just that we have these diseases, or we live with these diseases, or we die from these diseases, but we are disabled from these diseases as well. These are some statistics that show, close to 13% of people living in the community with chronic disability. Probably it's, did we lose? No, we didn't lose it. Probably it's more than that, but certainly you can see that it's a more aging population that have the highest rates of living in the community with disability. If any of you know the movie well enough, you'll know what is just about to happen at this stage of The Wizard of Oz, yes? The Scarecrow points Dorothy in the wrong direction. This scene is called The Wrong Path. So why do we go down the wrong path, and what relevance does it have for cardiac disease, stroke, brain injury, and cancer? Because we choose to. Because everything that we do is a choice. We choose whether to go left or right. We choose whether to eat a burger or eat a salad, etc. And a lot of our choices influence the path that we're going to take in terms of our health and certainly in terms of our likelihood of developing cardiac disease, stroke, brain injury, and cancer. I don't know whether you have this impression, but I certainly do when I talk to my patients, and they seem to be pointing at me as having the responsibility for their health. And I say, well, actually, it's multifactorial, and we all have a role and a responsibility here. So the individual, the patient, has a responsibility to take care of themselves. The physician, us, we, healthcare providers, have a responsibility. Our families play a role, too. You know that complex social situations are going to limit discharges and et cetera. So family, community, and the local, state, and federal government have something to do with it too. So when we look at this list, and sometimes say, well, if it's all these other factors, then really is there anything that I can do about it? So this was an interesting article. Oh, there's lots of references here, and I think they're all interesting, and I would say read them all. So if you're bored on a Sunday afternoon, then you should take these references and read them all. But this was about self-care prevention and management of cardiovascular disease and stroke. This came from the American Heart Association. And they sort of broke down self-care into the various different elements of what it looks like. So self-care maintenance is, what can I do about myself to maintain good health and to avoid some of those risk factors for disease. But if I get those diseases, then I need to do some self-care monitoring. How can I keep an eye on, be proactively involved with the observation of, monitoring of those risk factors? And then if I have them and they're not well controlled or they're not going away, then how do I manage them? So these are this is part of a sort of a self-care model that really helps us understand what we can do for ourselves. Based on this article, the American Heart Association came out with Life's Simple 7, and I think it really is very simple. And again, I tell my patients this every single day when I see them. These are the simple do's and don'ts that really make a difference to our life. So obviously, we shouldn't be smoking, and I won't ask you to raise your hands, but I'm sure none of you smoke. We should all be trying to maintain the best possible body mass index. Normal is between, 18 and 25, anything above 25, and we know we're heading in the wrong direction. Physical activity, I put it in red because that's what we're going to talk about. A healthy diet, maintaining obviously low cholesterol, normal blood pressure, and plasma glucose. So these are the simple things which if we take care of, then we're going to have a healthier life and hopefully avoid some of these diseases. A healthy diet also includes, from my perspective, no alcohol. How many people, don't put your hands up, how many people can say they don't drink any alcohol? Well, I said don't put your hands up because this is, I'm not allowed to ask you to disclose about your personal lives. But the truth is, and there's a study that came out in The Lancet, I think it was like 9 months ago now, maybe a little longer, in the last year, that looked at, it was a global study, and the safest amount of alcohol was 0. So this is very interesting. I talk about this with my patients as well, because this is sort of the conclusion of this, the study that I talked about that was published by the American Heart Association. Because what they're saying is that really our behavior contributes to about 40% of our overall health. And I think that's an underestimation. I think it's much more than that. And the reason is that genetics, we are discovering that genes are influenced by our environment and by our behaviors and our internal environment as well, i.e. what we put into our body. So if you smoke, your genes get altered by the tobacco smoke and toxins. If you eat poorly, then our cells and genetic material get influenced by that poor diet. If we don't exercise correctly, then our genetic material ages quickly. We see that people who exercise more have healthier telomeres on their chromosomes. So genetics, I think we can positively influence. This is not, something I can do nothing about. So I think we'll see that our behavior actually probably governs much of the genetic influence as well. So there's always something that you can do. So let's look around the country, and I'm going to show you 4 slides, and at the end of these 4 slides, I want you to tell me, you can tell me, which are the 2 healthiest states to live in. So this is physical activity, okay? This is our rates of, physical inactivity around the country. You start to get a pattern of where people are less active. The darker colors are those people who are less active. What about obesity rates? So similar kind of pattern. And diabetes rates? Oh, how about that? A similar kind of pattern. And what about hypertension rates? Well, you can see that in a certain region of this country, there's a lifestyle that does not lead to good health. But where were the two best states to live?
Colorado and Utah.
Yes. Who comes from Colorado or Utah? Who's going? All right. So the World Health Organization also feel that this is worth looking at as well, and they came out with an action plan. It's called the Global Action Plan for the Prevention and Control of Non-Communicable, as in non-infectious diseases, 2013 to 2020. They're sort of coming into the end of their action plan, but by 2025 they wanted to significantly reduce non-communicable diseases. What were those diseases? The things that we're talking about: cardiovascular disease, cancer, chronic respiratory disease, and diabetes. And what were the 4 things that they said that we can do? Don't smoke, don't eat poorly, don't use alcohol, like I said, and be physically active. Well, now we have to understand, what do we mean when we say physically active versus exercise? So when you wake up in the morning and you open your eyes, you have started to be physically active. But that is not exercise. That is not exercise is medicine, which is a nice phrase I like to throw around. So that's just activity. When you go to the gym and you look around you and you see people on the treadmill or the elliptical or whatever, and they're texting or they're reading the newspaper or they're having a wonderful long-flowing conversation with the person next to them, trust me, I don't think they're exercising. They're being physically active. Exercise is something that is much more prescriptive and much more accurate and has a precise prescription, which I'm going to get onto in a little while. But there's a difference between physical activity and exercise. I think we haven't quite sorted that out in the literature yet. There's still a difference because the question is still asked, are you physically active? And I think the two get interchanged, but I don't think we should be doing that. But anyway, physical activity and exercise, if you look around the world, about 1/4 of all adults are not physically active enough. I'm not talking about exercise, but just being physically active enough. And look at that. 81% of adolescents around the world are not physically active. Well, I have a 13-year-old and a 19-year-old, and I know why, because they're all playing Fortnite or whatever it is. Yeah, you know those games. So we've got to do something about that. This was another study. This came out before that previous one I was talking about, published in The Lancet, looking at relative risk for all-cause mortality, but also for risk of coronary heart disease, diabetes, breast cancer, and colon cancer, and related to activity or physical inactivity. And there's a very strong correlation between all of those diseases and all-cause mortality with the more inactive people are. So we see it on very large-scale population studies. So again, this is an extension of that study. 9% of premature mortality, so 5.3 million people worldwide due to physical inactivity. And if we could reverse that physical inactivity by 10%, we'd save 500,000 lives, and by 25%, 1.3 million lives. So, and also people would live longer. So physical activity has a worldwide influence. So here's where we are, right here in the United States. Overall, it's 1% to 19%, and of course on here it's so very small. Can you see what the numbers are there? 10 to 15, yeah. I have 54-year-old eyes, and I can't work out how to use my reading glasses very well. So here, 10 to 15% of our deaths are related to physical inactivity. Oh, there's a little island over here. You see that one? That's where I'm from, and I think that's a higher rate. That's over 15%, but I've adopted a more American way of life, and I'm thinking of moving to Canada, where I can be even more active, or Colorado and Utah, one of the two. These are factors that influence our self-care and are things that we need to focus on as well, and things that we need to understand in a rehabilitation model, but just in a societal model as well. That there are individual factors, including our mood and the number of diseases that we have that influence our ability to exercise self-care. If we don't have good social support, those people who are isolated, those people who don't have a loved one saying, come on, let's do something healthy, that will influence our self-care. And then if the community is not set up as well, if we don't have parks and recreational activities, if we don't have walks for MS and breast cancer, etc., then we don't get out there and be a part of the community. So what are the strategies that we can use to enhance our self-care, to improve our behaviors? Well, there's a number of strategies listed here, but I think technology really offers us a tremendous amount of help. And certainly within the field of rehabilitation medicine, where sometimes the resources aren't always there, but we can stay connected with our patients through mobile technology and treating people in their communities. Certainly in the field of cardiac rehabilitation, that's really a wonderful area of opportunity for growth. But technology can really help people stay invested and engaged in their care. So when we come to individuals with disability, we have an even greater challenge, and this is part of the problem. This was a study that came out in 2004. You can imagine the data was collected in the 1990s. So I don't think that there's been tremendous change in what we've been providing to patients. So this was looking at a group of disabled individuals and looking at what some of the barriers or facilitators were to their ability to be physically active or to be physically fit. And they interviewed a bunch of different people. They interviewed, obviously, individuals with disabilities. They interviewed architects. They interviewed people who are in the sort of the fitness and health world, and city planners and park and district managers. And they came up with 10 different factors that either facilitate or impede behavior or ability to be active, including the issues in the environment and economic issues and a whole host of them that you can see here. But clearly for our disabled population, this is a very complex situation. This is not easy. This is not like that duck on the water. This is, somewhat challenging, but we need to approach it. So, back to that slide that tells us what ails us and what kills us, and what are we going to do about it. So, when we think of cardiovascular disease, heart disease, a brain disease, peripheral arterial disease, and leading to amputation, then we've got to think about our modifiable and non-modifiable diseases, as well as cancer. The same kind of risk factors have been associated with cancer as have been associated with cardiovascular disease. And physical activity is right up there at the top of the list, alongside hypertension, smoking, dyslipidemia, diabetes, overweight, and obesity. But those are the major factors that we need to look at. There are mechanisms that show that physical activity can actually positively influence high blood pressure, dyslipidemia, diabetes. These are cellular, hormonal, genetic expression that is influenced positively by exercise that affect all of these risk factors. When it comes to weight and obesity, yes, it's complex, but it can also be looked at, again, somewhat simply in terms of calories in and calories out. A more active lifestyle will burn more calories. A less active lifestyle will burn fewer calories. But we certainly have, I think, the tool at our fingertips, and it is physical activity that helps to positively influence all those risk factors, which can then go on and cause, if we don't take care of it, can then go on and cause cardiovascular disease. So what should we be doing? How much activity? So our intrepid explorers now, so in The Wizard of Oz and on the Yellow Brick Path, you don't see a car, there's no bus. These guys are walking. Great example. Even Toto is walking. But this is what we should be doing. These are the 2008 physical activity guidelines. They were updated in 2018 last year, but I don't think that adds anything more to what was said in 2008. But so here it says, what the minimal requirement is. Understand that word minimal? That's the lower threshold, 150 minutes. Lots of people quote that as being, oh, if I've got 150 minutes a week, that's great. But this is where you should be, 300 minutes. Okay, you can, you don't have to, don't. Raise your hand. But who exercises 300 minutes a week? That's 5 hours a week. Who does 5 hours a week? Okay, I said don't, so I don't know how many of you really do or don't. But you know in your heart whether you do or you don't. But I know many of my patients don't exercise 5 hours a week. And when I tell them, oh, you should be exercising 5 hours a week, you know what they do? Ah! They laugh at me. But I do. I get up at 10 to 5 every morning, so I'm in the gym. I'm actually in the gym from 5 till 6:20. 4 days a week, and then I play an hour and a half of soccer on a Sunday. So I get it in. I live it because I believe it. But this is what we should be doing. So how many of us are actually doing that? This is adults. And how many adults are achieving the physical activity guidelines? That's the 150 minutes, not the 300 minutes. So we're just about at 50%. We're doing better. The trend is up. We're doing better. But if you look at the age groups, it's actually the younger folks who are doing better and the older folks who are doing worse. This trend is in the wrong direction. What about when we combine aerobic exercise with resistance exercise? Because they're back on that slide, it did say 2 to 3 days a week of resistance exercise as well. We're even worse. Only 20% are getting the combined amount of both. And again, a similar trend from the younger ages down to the older ages. So why aren't we more active? Why don't we exercise? Well, it's, again, not straightforward. It's complex, and I know I have heard, and you've probably heard all the excuses under the sun. You know, fatigue is a big one, and fatigue is an interesting one. So I picked out fatigue so that I could talk to you just a little bit about it. So we understand that there's general fatigue, or fatigue just generally, like, you know, we can all experience it, and there's fatigue in disease states as well. So let's talk about general fatigue, and these next few slides come from this article. It's a very interesting article by Evans and Lambert. Again, well worth reading through if you're interested in fatigue. But they define fatigue as a physical or mental weariness. Yes, you've experienced that. You know what it is, and your patients may also complain about it as well. And it's an inability to continue the exercise that you're doing. In fact, that you actually probably have to stop or pull back from the exercise that you're doing. And this exertional fatigue is related to deconditioning. We're going to talk a little bit more about deconditioning in a little while. It's probably related to your muscle mass, not just your muscle mass, but the functioning of your muscle as well. You've heard of the term frailty. Yes, and frailty leads to sarcopenia, and it tends to be this condition of loss of muscle mass, but it's not just a loss of the mass, but the muscle itself is not functioning well. There's a whole science of sarcopenia. It could be another lecture altogether, but it's very, very interesting, and it's not something that's inevitable. It's not. But anemia as well, if you don't have blood cells to carry oxygen, poor oxygen extraction or poor oxygen delivery if you have lung disease, and just in general poor nutrition or malnutrition as well. There's a pathophysiologic classification, this physical fatigue we were just talking about associated with muscular effort. You've been there, you've been in the gym, you're working out for an hour, you're starting to get tired in those muscles. Through the day, you're going to feel it, that sense of fatigue in the muscles. It's actually a nice feeling, but still, it's there, it's fatigue. And then somatic, which is considered perhaps more primary. It's a little more difficult to define, but it's without physical fatigue, without a physical exertion, but people just generally feel tired. Teasing out that mental or psychological classification as well. Mental, yes, you've been taking an exam, you're into the third hour of the exam, and you just can't focus anymore. That's that mental fatigue. And then a psychological fatigue. If you're anxious or depressed or of blue mood, then you have this lack of interest and motivation. So what about fatigue in sense of physical fitness? Well, I deal a lot of this in the cardiac field in terms of our fitness level. If you remember from basic physiology days, the Fick equation, the VO2 is how much oxygen your body can use. Oxygen equals energy, okay? You've heard of METs, not the New York Mets, but that unit of energy, 1 MET is your basal metabolic rate. So the Fick equation, how much oxygen you can utilize is related to how well your heart is pumping and how well your body is at extracting oxygen that's delivered around the body. So those are the central factors and the peripheral factors in terms of our determinant of VO2. And we know that when we perform regular exercise, we can increase our VO2 because we can increase our cardiac output. Very importantly, that is significantly related to increasing our plasma volume expansion. So it's one of the earliest changes in our cardiac output, but it's also one of the things we lose quickest when we stop exercising, is that your plasma volume shrinks back down again. And in terms of our ability to extract oxygen, it's a whole host of different factors. These are some of the bigger ones. Capillary density increases, mitochondrial density increases, and myoglobin, which has a higher affinity for oxygen than hemoglobin does at attracting the oxygen from the red blood cell. So what about fatigue? You've been there, you've experienced it. You may have got a Charlie horse or a cramp or overdone it and have hit that wall. That wall is when you're reaching what's called lactic acidosis, lactate threshold, anaerobic threshold. That's where we are converting over from aerobic metabolism to anaerobic metabolism, and that lactic acid builds up. Whenever you've experienced that, then you are going to experience that mental fatigue, the drive to respiration because you are now in an acidotic environment, tachycardia. These are the kinds of changes that we feel when we cross that threshold of fitness. Lactic acid is going to come up again in a little while in relation to cancer. What are the other causes of fatigue? Well, if we haven't fed enough, we don't have enough glycogen, if we have not drank enough and are dehydrated, temperature regulation issues, vitamin D as well, also related to fatigue, and dopamine depletion as well. So a number of different factors also contribute to fatigue. That was generalized fatigue. Well, what about fatigue in disease states? Well, if you take care of patients with traumatic brain injury, you'll understand and you know that many of these patients will complain of fatigue, ranging from 30s to 70%. Even in people with mild injuries, mild concussions can have fatigue, but more prevalent in those with moderate to severe injuries. And it's related to neuronal injury. It's in those areas of the brain where you see the most impressive diffuse axonal injury. This fatigue and traumatic brain injury, it's associated or it's more prevalent in those environments or times when there's increased effort, not just physical effort, but mental effort. There could be neurohormonal abnormalities, including abnormalities of growth hormones, and then there are neurotransmitter issues as well. So there are some complexities to this. This is a model of fatigue and traumatic brain injury. Obviously, it links the neuropsychological, the endocrine dysfunction, the exercise issues, but it all sort of relates to how fatigue develops in an individual with traumatic brain injury. Again, it's not just an acute issue, and it can be a very chronic issue as well. What about fatigue and stroke? Also very prevalent. Also multiple factors are related to fatigue and stroke. But I think one of the very interesting ones is this issue with sleep disorder. It's very common in people with stroke. In fact, sleep disorder is very common in people with cardiovascular disease in general. I don't know how many of you actually ask your patients about sleep. Difficulty getting to sleep, difficulty staying asleep, snoring, fatigue when they wake up, and falling asleep during the day. These are some of the markers of sleep disorder and very much associated with cardiovascular disease and stroke and fatigue and stroke. And this is a model of fatigue and stroke. Again, I'm not going to spend too much time on it, but it's a very interesting model of how fatigue originates and then feeds back into itself. This was a study that was published back in 2012, and it was a study to look at cognitive therapy versus cognitive therapy combined with graded exercise therapy or graded activity in terms of combating fatigue. And what they found was, after a 12-week intervention, that both cognitive therapy and exercise therapy or activity improved fatigue, but there was no doubt that the combination of the two was better than the one alone. So again, you cannot hope to overcome fatigue and stroke by only giving cognitive therapy or perhaps only giving exercise, but you should be combining both modalities. What about fatigue in cancer? Also very common as well. 74%, 3/4 of patients who have cancer will say that at some point in their course they have fatigue. And on a daily basis, 1/3 of patients with a diagnosis of cancer will complain of fatigue. Many of them have had it for many, many years, and sadly 50% it's never been discussed with their clinician, and only in 25% has any intervention ever been proposed, 25% of those that it's been discussed. So, we're not doing a very good job in cancer in general in terms of understanding or talking about fatigue. Again, it's multifactorial in its origins, probably a lot related to the tumor, a lot related to the tumor therapy, pain, anxiety, metabolic issues, other comorbidities that may be coexistent or may develop subsequent to the diagnosis of the cancer. Opioid analgesics may have something to do with it. So sleep disturbance as well. So again, this is multifactorial. This was another review article, by the way, again, well worth reading over, published in 2012, and it really talks about exercise recommendations. This is where I got a lot of the information about fatigue in cancer. Talks about a lot of the exercise recommendations to try to overcome fatigue in cancer. And so, again, well worth a read. And what about fatigue in cardiac disease in the area that I work in? Again, I see it across the board. In heart failure, it's the most common we most commonly see fatigue out of all the diagnoses in heart failure, but you see 70 to 80% of patients will have it. It gets worse with rest. It's very interesting. I think a lot of these fatigue states get worse with rest. Many times it's our inclination, oh, if I'm fatigued, I'm going to rest. I'll feel better once I've had a nap or a rest or sat down for an hour, but that's actually not the case because we worsen our deconditioning. It's associated with poor cardiac output, metabolic abnormalities, neuroendocrine and hormonal abnormalities, endothelial dysfunction, and of course mood and emotional disorders as well. So here we have a state of affairs where we're dying from preventable diseases. We understand we have something to do with it. Fatigue has a lot to do with it, and we understand that in brain injury and stroke and cancer and cardiac disease, it's multifactorial, it's complex, but what can we do about this? Well, we have to understand initially what the concept is of motor activity, and you'll see here, the evolution of motor activity from a sedentary behavior all the way up to exercise as medicine, and then exercise is rehabilitation. And when I use the word exercise, I mean aerobic exercise, although I am corrected. Many people will say to me, yes, but what about the resistance exercise too? That's also very important. That's a topic of another talk. You'll have to invite me back. So we have a long history of understanding about heart disease, about activity and the benefits of exercise. Right back to the 1950s, that London bus you'll recognize, that was one of the earliest studies to look at activity and exercise in London bus drivers, and found that those who were more sedentary had higher risks of cardiovascular disease and those that were more active. And these people were driving around for 8-10 hours a day sitting down. But we've had a long history of articles being published about the benefits of exercise. So again, a little bit tongue-in-cheek, but exercise equals life, exercise equals immortality. I do say that to my patients. Again, they give me a chuckle, and then I add that little term, or phrase, nearly. But I do believe that while we cannot become immortal, we can approach immortality, and that's not from an ego perspective. So this is very interesting. This research looked at endurance-trained individuals, and these were endurance-trained individuals who really endurance-trained for most of their lives versus sedentary individuals who were sedentary for most of their lives. So look at the decline. This is the VO2. This is the oxygen carrying capacity. Look at the decline in the sedentary individuals. So here they are at 50 years of age, and physiologically they're equivalent to an 80-year-old trained individual. So that's very, very interesting. Alternatively, an 80-year-old individual who's trained all their life is physiologically like a 50-year-old. Okay? So physiology has a lot to do with our life expectancy, and it's borne out in this slide as well, which shows you that the relative risk for all-cause mortality is absolutely directly related to the fitness level you have. The least fit to the most fit. The more fit you are, the longer you're going to live. I like that idea. This is why I go to the gym. I tell my patients as well, they chuckle too, I'm going to live to 100, at least 100. And it is a little funny, but it's not. There's no reason we shouldn't expect to live well into our hundreds if we follow life's simple 7. This was a study looking at physical activity in an older individual group. And again, the benefits of exercise is not just for youth or middle age or across the board. But this was a study that looked at walking, physical activity in a group who were older. I think the average age was 73 years of age. And they found that physical activity was inversely related to coronary heart disease and stroke and death. So again, a direct correlation between activity, walking, and survival at any age. Do we have examples of medicine, of exercise as medicine and rehabilitation? Well, the answer to that is yes. We have in general, and I have 20 of those 30 years, but it's at least 30 years, probably much longer than that, back to the 1970s, where we started to understand about cardiac and pulmonary rehabilitation, about the benefits of aerobic exercise in that population. So we're getting close to the Emerald City, our goal. They just had a nap, by the way. They're coming out of those flowers. That's where I think they were drugged, weren't they drugged? Didn't they all fall asleep? Didn't Toto fall asleep and Dorothy? I haven't seen it for a while. Did I? No, okay. So what is the cardiac rehabilitation model? And then again, you know, I'm giving you this because I think this model should be extrapolated to what you're doing in stroke rehabilitation and cancer rehabilitation and brain rehabilitation. So think about this as I talk about it briefly, how you could perhaps incorporate this into your other models of care. But it's a comprehensive approach. Yes, that's what we do in the rehabilitation world, and we look at the patient from toes to nose. So you know, it's not just about looking at a region or an organ system, but we look at absolutely everything in terms of our history and physical and our tests and our management plan. And the management plan, we sort of have our feet in both spheres of primary care and specialist care. But primary care, from my perspective, I'm always looking into and asking, and I may not be ordering the test, but I'm pushing the primary care physician or the cardiologist, make sure that they have checked out the lifestyle risk factors as well, and make sure they're on the right medications and make sure they're taking their medications. And then as a physiatrist, because these patients come with all different levels of strength and mobility, so they may need a more sort of basic comprehensive plan of physical and occupational speech therapy. Many of them have cognitive or emotional issues that are clouding their path, so psychology, nutrition is very important, and then the cardiac rehabilitation program. So the cardiac rehab program always starts, other than that evaluation, with a stress test, because we have to understand what the body can do and how hard the heart has to work to get the body to that level, and to make sure there's no major disasters on the horizon, like for cardiovascular disease patients, arrhythmia, heart failure, or ongoing ischemia. These are the major issues that we check for in a stress test. We want to know what their functional capacity is. We want to make sure they're safe on equipment, because you're going to put someone on a bike or an elliptical or a treadmill or a rower. We want to make sure that from all perspectives they're safe. We want to make sure that we understand their risk for a problem, a medical problem or any other kind of issue, because that comes into our exercise prescription. And the exercise prescription is the crux of the matter when it comes down to exercise as medicine. So the exercise prescription, we abbreviated into the little term there, FIT-P, frequency, intensity, type, and time, and progression, which I'll come on to again in a little bit. But in brief, it's 2 to 3 times a week when somebody's on a sort of an insurance paid for outpatient program, 2 to 3 times a week, 36 sessions, typically aerobic exercise, but we also do incorporate some resistance exercise as well. And for some patients, high intensity interval training is also important, and then flexibility, posture, and balance as well. The idea that cardiac rehabilitation is a lifelong program, so it's not just 36 sessions, and I do dislike intensely the term maintenance therapy. I prefer the concept of lifelong exercise, lifelong training. So we transition our patients from outpatient cardiac rehab into lifelong training. And before we launch them onto their own, we get an exit stress test. We compare it to the first one to show the progress and confirm the gains, make sure they're safe, and we modify the exercise prescription. And then we try to ramp up the frequency. Like I say, I tell my patients 4 to 5 days a week, target 300 minutes of moderate intense, hot, hard, sweaty work. That's what I tell them. They got to leave that gym, puffing a bit, a little tachycardic, sweating a lot, and fatigued. There's the FIT formula: frequency, intensity, time, type, and progression. Typically, the type is aerobic training, although we do bring in aerobic training as well. The goal is up to 4 to 5 times a week. Anything is better than nothing. So this was a study called, I think, the Weekend Warrior study, and it looked at individuals who were inactive, got no activity whatsoever, all the way through to those who were sufficiently active, and they met their goals of the physical activity guidelines. And what they found was that the all-cause mortality was significantly decreased with the greater frequency of exercise, from those who were inactive to those who did it once a week to a couple of times a week to 3 or more times a week. And what about the intensity of exercise? So here, this is people who got no physical activity. They had a crude death rate of 8 and change. Anyone who does a little bit more than no physical activity, even below the 300 minutes, has a reduced crude death rate. But once you start to introduce some more vigorous activity, so this was 0 to 30% of the time was vigorous activity. Here, yes, sir?
Can you tell us the operational definition of vigorous? What's vigorous?
Yeah, so vigorous, I think, was like over 6 METs, which actually, in my book, is actually not that vigorous. It's actually somewhat mild, but that's how it was defined in these studies.
What kind of exercise will give you 6 METs?
Uh,
Can it be running, can it be walking?
No. This is not walking. This is what you're going to feel is sort of a moderate, intense experience when you're exercising at that level. Okay, so you're going to feel that your heart rate is getting up. You're going to feel that sense of fatigue. You're going to be getting hot. You're going to be getting sweaty. Again, if you think of it in terms of conversation, you're going to be able to speak in short sentences as opposed to long paragraphs. Okay, so it's a perception as well. The RPE scale correlates very well. The RPE scale of 12 to 14 correlates very well with this kind of intensity of exercise that we're looking at.
Thank you.
You're welcome. So when we start to bring in more vigorous activity in terms of the amount of time, then we start to see that our death rate decreases. So the lowest amount of death rate is 300 minutes with at least 30% of that time at a high intensity level. These are a couple of references that if you're interested in high intensity training are very applicable to the cardiopulmonary field, but this is in terms of what the model looks like. So this is a steady state, the darker line, and this is the interval training with 3 or 4 intervals for every piece of equipment. This is in terms of the time. This is an interesting study as well in terms of the time. So if people are not exercising at all, they're at their baseline, they're sedentary. Even those who have less than the physical activity guidelines in terms of the amount of time, they have a reduction compared to the sedentary lifestyle. And those who reach actually over the physical activity guidelines, this is about, I think, 400 to 500 minutes of exercise a week, they have the greatest reduction. What's interesting here, and this is I think 10 times so these are the ultra marathoners, the iron folks, men and women. It's not always so good. There is probably increased stress through the cardiovascular system, increased inflammation, which actually increases their mortality risk. So, the old adage, if something is good for me, more is better, that's not always the case. So what about cardiac rehabilitation as medicine? Cardiac rehab really having an influence on the outcome. So this was a study published back in 2010, the relationship between the number of sessions attended in terms of cardiac rehab and death and myocardial infarction at 4 years. So we're looking at exercise, not blood pressure control with this medication or cholesterol control with that medication, but exercise, and did it have an effect on your risk for death and heart attack? Well, the answer is yes. So these were the people up here in the dotted line who got the fewest number of sessions. And you can see this is the cumulative incidence of death, a lower risk of death after 4 years for the more sessions, 36 sessions. So these were people who did 36 sessions, and then we didn't tell them whether they should carry on exercise or not. They just lived whatever lifestyle that they had incorporated or continued. But 36 sessions, 3 months of exercise, produced a significant reduction in mortality 4 years later, and the same for instance of myocardial infarction compared to those people who did fewer sessions. So there's clearly some hangover effect of the benefit of cardiac rehab. And this was looking at readmissions on mortality. I think this was over a period of 10 years after myocardial infarction. And this is the hospitalization or the readmission rates. But you see a 50% reduction in mortality rates for those people who participated in cardiac rehab versus those who didn't. So cardiac rehab, the model, the exercise is medicine. It does have significant positive outcomes for patients who have cardiovascular disease. Jumping over a few slides just to make sure we've got time. So what about exercise as medicine in the field of cancer? So what does epidemiology tell us? Well, if you look into terms of populations, we understand that those people who are the least active have the highest risks of these cancers: prostate, breast, colon, lung, ovary, and endometrium. This was a study, a global study, nearly 1.5 million patients, and they pulled the data and they looked at leisure time physical activity and risk for cancer, and found that those who had the highest levels of physical activity had the lowest risk of cancer in these kinds of cancer. Okay, so compared from the highest amount of physical activity to the lowest amount of physical activity, you had a significantly lower risk of cancer in these 13 cancers. Another epidemiologic study, a meta-analysis done in 2009, looked at risk for colon cancer and found that those people who were active had a 24% lower risk of colon cancer compared to those who were the least physically active. Similar study in breast cancer, okay, reduction of risk of breast cancer by 12%. Similar in endometrial cancer as well, reduction in higher physical activity versus lower physical activity by 20%. So that was the risk of cancer in terms of epidemiologic studies, and these quotes are all about patients who have been diagnosed with cancer and the risk for cancer recurrence. 35% lower risk of breast cancer deaths in people who exercise, 41% of risk of all-cause mortality, 24% low risk of breast cancer recurrence. Similar statistics in terms of colorectal cancer, in terms of exercising, physical activity that was started after the diagnosis of cancer. And it's complex. It's not straightforward. There's not one reason why exercise improves your outcomes in terms of cancer. Probably related to various different levels of hormones, obesity, insulin resistance, inflammation. I'm going to show you a slide in a few minutes about inflammation, and a leading researcher who's talking about inflammation and cancer. A function on the immune system as well. Lactate production, I told you we'll talk about lactate and cancer in a few moments as well. Transition time of bile acids in the gut. And genetics, gene expression, epigenetics, again, probably has a significant impact on your risk for cancer with exercise. So this is just a model of what I said in terms of the benefits of exercise having effects on sex hormones and various different inflammatory markers and signaling molecules in terms of cancer development. So I don't know if any of you have heard of Inigo San Millan. He's a researcher out in Colorado in the rehab department out there. And he talks about a physiologic mechanism called the Warburg effect. And it is all about the production of lactate and lactate's influence on cancer. And again, I put this here not to go into tremendous detail about it with you today, but lactate, that byproduct of inefficient exercise, that byproduct of a sedentary lifestyle, is associated with carcinogenesis. And so therefore, we need to recognize that lactate plays a role here, and exercise plays a role in improving our metabolic pathways, reducing glycolysis and improving our oxidative metabolism in the mitochondria. And that shift from dependence on glycolysis to aerobic metabolism through the Krebs cycle in the mitochondria helps to spare the body of this lactate overload, and therefore is probably one of the reasons why we see a reduction in cancer in those people who are aerobically fit, because they have better abilities to shift away from lactate production. Again, read the reference. It's tremendously interesting. This is another researcher. His name is Lee Jones. He works now up at Memorial Sloan Kettering. And again, he has a slightly different theory in terms of the etiology of cancer. And it's based on inflammation, chronic inflammation and inflammatory markers, and the effect of inflammation on immune modulation and the role of immune modulation in tumorigenesis in cancer. And he's done most of his work in the mouse model, the murine model. But again, read his research. It is so compelling in terms of the reduction of inflammatory markers with aerobic exercise and the delayed growth of tumors. So this was a study that looked at mice who were injected or transplanted with a human breast cancer model. And the top line is those individuals who were sedentary, and the bottom line is those individuals, the mice individuals who were active. And this is the weight of the tumor. So you can see that these lines are diverging, that the tumor grows far quicker in sedentary individuals than it does in active individuals. And this graph here, this is looking at the sedentary individual and then mice that were treated with chemotherapy and alone and exercise alone, and then this dark line is the chemotherapy combined with aerobic exercise. Those mice that had chemo and exercise had the smallest volume tumors. We've got to show that that's the case in the human model, but this is a human breast cancer model in mice. Again, very compelling data, and again, very well worth a read. So how are we doing in terms of activity, promoting activity and exercise? So those people who have cancer, very few of them are actually exercising, and as they recover, still far fewer than we would like to exercise are being active. So we need to think about that. If you have a cancer rehab program here, if that's an area of interest of yours, you've got to think about how you're going to be able to get in there and motivate these patients to exercise and give them goals that they're able to achieve and get them on that path so that you can get your patients who have been diagnosed with cancer to exercise, because it makes a difference to their outcome. This was a Cochrane review in terms of not just outcome in terms of survival, but in terms of quality of life, and showing that in cancer survivors, physical activity was related to reduced fatigue and depression and improved quality of life. Here's some more reading for you as well. The couple of articles are going to be published. The American College of Sports Medicine is going to come out with some statements later on this year. And again, I really encourage you, if you're interested in this field of aerobic exercise in cancer and cancer rehabilitation, that you should be reading these things. So what about exercise as medicine for the brain? This is Julie Basso and Wendy Suzuki. I think Wendy Suzuki is up at NYU, but this is also interesting data. I made it a little bit larger. Of course, I cannot see this at all from the slide here, but this looks at various different behavioral models and I think neuropsychological models and et cetera, in terms of the influence of exercise on various different markers within the body. This is, again, done by Wendy Suzuki. This was a study of the neural effects of exercise. You know, you got your little mouse on a running wheel here, and there is some data to show that there's hippocampal neurogenesis, and that therefore improves learning and memory and mood. And this is all related to this myokine cathepsin B that gets released from the peripheral muscles exercising, that crosses the blood-brain barrier, gets into the brain, and improves neurogenesis in the hippocampus. This was an extension of her study by two other researchers, and they looked also at the hippocampus, and these are brain biopsies of sacrificed mice. These black dots represent neuronal activity in individual mice. These mice were sedentary. These mice walked around a maze, and these mice ran on that running wheel. So the more activity you had, the more neuronal activity you had, and this is essentially neurogenesis, this development of new neurons. So this was the hypothetical model that they put down. Again, the study's been done in mice. It's a little harder to sacrifice human beings and test their hippocampi, but I think this, the models are close enough to understand that exercise improves our neurogenesis centrally. This was a study looking at dementia. It didn't mention whether these patients had Alzheimer's disease or not, so I'm not going to claim exercise as a cure for dementia, although I'd like to. But again, this was a model that looked at brain-derived neurotrophic factor and hypothesized that exercise improved brain-derived neurotrophic factor, and therefore would have a positive influence on the rate of progression or even the chances of developing dementia. What about concussion? So this is very interesting as well because you see a lot of exercise intolerance after concussion, and it's felt that that's related very much to abnormalities in the autonomic nervous system. And the autonomic nervous system controls ventilation. So you see an abnormal ventilatory pattern in individuals who have had concussion, and it actually leads to an inappropriately low rate of respiration in individuals when they're exercising after a concussion, and therefore they have elevated levels of carbon dioxide, and those elevated levels of carbon dioxide cause vascular changes in the brain, which lead to headache, dizziness, and fatigue. So this is a sort of somewhat theoretical, but also known to occur as well in terms of ventriculary abnormalities in individuals who've had a brain injury. So this group, John Leddy, is a leading researcher in this field of exercise in concussion and these symptoms. They developed this test, the Buffalo Concussion Treadmill Test or bike test, to really try to understand what the right dose of sub-maximal exercise is for individuals who've had concussion, who need to exercise, but don't want to get to that point of hypercapnia that they're starting to have symptoms of headache and dizziness and fatigue, because when you feel like that when you're exercising, you're going to pull back from your exercise. So this was the model that they devised, that divided patients into sort of 4 different groups, and depending on how they did with the exercise training test, if they had no symptoms, then they were free to get on and return to sport, and if they had some symptoms, depending on what they were, then it would dictate the different kinds of rehabilitation care that these individuals had. And one of the models that he looked at was female college athletes who had concussion, and found that they had elevated levels of arterial carbon dioxide. And he trained these individuals and found that using his model of evaluation, the treadmill or the bike test, to find a sub-threshold, so a level of aerobic exercise that did not induce symptoms, he was able to help these college athletes overcome their concussion symptoms far quicker than those individuals who didn't exercise. This was another study also by Leddy. In fact, I think this one was just published in February of this year. This was the first prospective randomized controlled trial of subtherapeutic aerobic exercise in individuals with concussion, finding that there was a significant improvement in time to recover. These were the sedentary folks. These were the ones who were exercising, and on a randomized controlled prospective study found that aerobic exercise sped the time for recovery and reduced the severity of the symptoms of post-concussion syndrome. This was a study that was done that I put in here to sort of indicate that this is not just necessarily an acute intervention. This was a group of individuals who were involved in a walking versus a nutrition program on average 8 years after they had a traumatic brain injury. And the outcome showing that there was no benefit of a nutrition program, but absolute benefit in terms of reduction in fatigue and increase in step length through a walking program. So even 8 years following a traumatic brain injury, the benefits to aerobic exercise for individuals with traumatic brain injury is noted. This study was a systematic review of looking at aerobic exercise and quality of life in patients who had stroke, and found that when you pooled all the data together of individuals who had had stroke and who got involved with aerobic exercise, found that the aerobic exercise improved their aerobic fitness, improved their walking speed, improved their endurance. Again, a very good article to read, because at the end of it, it gives you this model of a rehabilitation program that you can take right from these pages and put right into your system of care for individuals with who have had stroke. It's very prescriptive and it's very effective in terms of outcome. So this was a study as well that was looking at neuroplasticity and the benefits of aerobic exercise. And the reason I put this one in here as well is because in the acute rehabilitation stage, the value of aerobic exercise is that it primes the body for neuroplasticity. So when I was at medical school back in England in the 1980s, neuroplasticity was only something that we talked about in terms of children. Once you reached a mature brain, then we did not think that there was any neuroplasticity still to be operated on. But now clearly we're understanding that neuroplasticity continues throughout the lifespan. But it is the timing of the aerobic exercise in the acute stage that really can enhance or prime the brain and prime those neurotransmitters to then enhance the recovery of a stroke-directed rehabilitation program. So if you have a patient with a hemiplegia and a weak hand, get them to do aerobic exercise, that primes the brain with all these neurotransmitters, and then they're going to benefit more from doing their hand-focused rehabilitation. So, do we have a magic pill? I happen to think yes, but I'm very biased. I believe all this data. Again, I may be very biased. But I think there's a growing amount of evidence that shows the value and the benefit of exercise, not just in cardiac rehab, but I think there's compelling evidence in cancer in terms of prevention and in recovery and prevention of recurrence, in terms of prevention and recovery in terms of stroke, and in terms of management in terms of brain injury. And I think there's probably much more to be learned in terms of rheumatologic disorders. So we're just about knocking on the door of the Emerald City now. I think we're sort of reaching the end of our journey, and hopefully you have some understanding of the value and benefit of where aerobic exercise can play a role. So that's the question really I have for you. How are you incorporating or going to incorporate aerobic exercise as medicine in your rehab program? You have examples of cardiac rehab and pulmonary rehab. Cancer rehab is getting on the bandwagon as well. There are plans afoot to establish a prospective study based on a cardiac rehab model of aerobic exercise in cancer rehab population to look at outcomes. I think the same should be done in terms of brain and stroke rehab, in other neurologic conditions as well, in immunologic mediated disorders, of rheumatologic conditions, and a lot of the arthritic conditions as well, and then in any area where we feel that genetic health or expression is influenced as well. How do you incorporate this cardiac rehab model? Well, it needs to be a comprehensive program. It needs to be across the continuum of care. It's never too soon to start, so you can go into the ICUs and you can go through a lifelong interaction. Again, we've got to change behaviors, our own as well as those of our colleagues and our patients. We need to make sure that we have compliance, because this is not 36 sessions and then you're cured. This is lifelong, so you've got to keep it up. We need to partner with our specialist teams. We can't do this alone. And we need to build it. We need to make it relevant to the healthcare environment, so building it into value-based management, showing that your intervention in the acute stage and the chronic stage can actually alter the course of disease and therefore be a cost savings to the system, but also be of value to the patients. So what's the next steps? We need to do research, there's no doubt about it, but you can start now. You can think about what you're doing now about incorporating aerobic exercise into your current programs. And then also, when you prescribe physical therapy or occupational therapy for your patients, why not add on aerobic exercise? You can do just 10 minutes of aerobic exercise at the end of your physical therapy program. So what are my plans for the future when I take over the world? I think this needs to be part of departmental strategic planning. I think it needs to be part of a health system strategic plan. I think AAPM&R, all of our organizations, Association of Academic Physiatrists, AHA, etc., they all need to be on board. And I think we need to affect and change residency training as well. And we think we need to add aerobic training into the focus there and think of this across the board. At 1:28, I think I made it with 2 minutes to spare, which saves me from any significant questions. But thank you for listening, and I hope, as I said at the beginning, that you will think about aerobic exercise as a way to treat your patients as you manage them in every stage of your care. Thank you. I'm happy to take questions.
I have a brief question. I know you were making a point about being physically active versus exercise,
Yes.
aerobic exercise, and I wanted to get a better, clearer view in terms of what do you define as the aerobic exercise component. Are there specific parameters that we would like to have as a guideline for our patients to follow, to be able to kind of achieve the number of minutes required to actually see benefit?
Yeah, so that's another lecture as well. But in brief, so as I said, when you wake up and you open up your eyelids, that's activity. And when you're walking around and going to work, that's activity. But the exercise needs to reach a certain threshold, a certain intensity. And typically we do that through a heart rate. And that heart rate intensity, certainly in the cardiac rehab world, in terms of risk factor modification, needs to come from that stress test that we do. A more complex stress test is called a CPET, a cardiopulmonary exercise test, that helps us understand anaerobic threshold, and we tend to want to exercise patients below that anaerobic threshold, so we take that into account, the metabolic fitness of somebody and their heart rate, and then we come up with a heart rate zone that allows people to exercise in a safe zone below that anaerobic threshold, and then It's part of the prescription. If we're talking about prescription for exercise, it needs to be that intensity, it needs to be a certain frequency, up to 5 days a week, and it needs to be of a certain duration, 1 hour each time or 300 minutes. So that's how you're going to get your patients into an aerobic zone. It doesn't happen overnight. So last weekend I was out at the Shirley Ryan Ability Lab, and they are incorporating aerobic exercise, higher intensity training in their stroke patients. They're acute stroke patients, they're putting them on a treadmill and harness-supported walking, and they are getting them to do higher level of exertion. Higher level than what? Well, if they weren't supported and weren't on the treadmill and didn't have the therapist helping advance their legs, they could walk maybe 10 steps in 5 minutes. But here they're walking at 2 miles an hour, 2.5 miles an hour with harness and therapy-assisted ambulation. Their heart rates are increasing. So it's a scale, a graded scale. Hopefully that stroke patient that I saw walking is going to recover to the point where they can do their own bike and treadmill exercise and reach that threshold, that heart rate threshold that allows them to exercise just below the anaerobic threshold. Long-winded answer, but I hope that gives you some kind of guidance.
Great talk.
Thank you.
As you mentioned briefly, I wanted to hear a little bit more about it. One of the hottest trends in exercise physiology these days is high-intensity interval training, and hopefully accomplishing more in less time, which is one of the big impediments to getting people to exercise. Where do we stand in terms of the evidence base for that, in terms of achieving some of the same goals with that type of exercise program?
So there are proponents of high-intensity interval training, and there are those who don't support it. I think you have to be very careful in terms of who you're prescribing it for, because, in terms of the physicality, the balance and functional ability, whatever machine you're on, you have to make sure you've selected the right patient. And in terms of, stability, medical stability, so my population, arrhythmias and heart failure and ischemia, we have to be careful that we're not putting them into a zone where they're going to have abnormalities. But that's the value of doing the stress test before you prescribe an exercise program for someone, because hopefully they've reached the peak of exercise on that stress test, so you understand where they are when they reach their high intensity. In the cardiac field, there's strong evidence that it's beneficial and not more risky, but it doesn't prove or doesn't show from the literature that I've reviewed that it's any better than steady state. Then it comes down to the individual patient, because many times patients will prefer to do a shorter course of therapy, a more intense exercise session. They're not getting greater benefits than those people who are doing the full session of steady state, but they're getting as good improvements and with no greater risk in the right selected population. I have not seen literature on high-intensity interval training in stroke, although I imagine, based on what I saw a week or so ago, that out of Chicago, we're going to have some data in the not too distant future, nor in cancer or brain injury. But that's where the research needs to come in. But it's safe, it's effective, but not more effective than steady state exercise. It's a trend that many folks are enjoying, certainly younger and maybe more balanced and mobile.
Any thoughts on balancing things like strength training with aerobic exercise? So for example, I know in the cancer rehab population, strength training really was working for people because of therapy and radiation.
Yeah, so I think, put a little disclaimer, or said a little disclaimer, that I'm not going to be talking about resistance training or strength training, and it's absolutely right. One of my colleagues in the cancer rehab world, every time I say, we got to focus on aerobic training, he says, and strength training, and strength training. Yes, absolutely right. So this whole idea of frailty and sarcopenia is absolutely related to sort of a catabolic state that we see in cancer, but many other conditions, heart failure as well, loss of muscle mass, loss of muscle function in the pulmonary world as well, in patients who've been on steroids where the muscles aren't working normally, and steroid myopathy. So absolutely yes. Again, it would be another lecture. I'll come back. I'll do another lecture on strength training. But you're absolutely right. I'm a little biased, and I didn't give resistance training enough of a comment, but it should be on an equal setting.
Great talk, and I really appreciate the evidence base you presented, and it motivates all of us personally to think about increasing our activity. I think we need to come up with another lecture on how to deal with the financial planning that my money's running out at 92, and you're telling me I'm going to live to 100. So if I exercise more, I can save more money. So it's a really challenging thing to be done.
So
another lecture you can consider.
I wouldn't be so bold as to give you financial or life planning, but don't stop working. Because you're going to live a long time. Good point, though.
I just wanted to know, like, what strategies have you found that you use in order to help your patients kind of stay consistent with this lifestyle after done with the program?
Yeah, so I follow with my patients lifelong. Until they're sick of me and bored of me and don't come back, I keep inviting them back, whether it's every 3 months, every 6 months, every year. They come back to see me. I play the role of their primary care doctor. And it's not about the exam. It's about the interaction. And I treat my patients, I tell them, I say, you know, you're a human being, I'm a human being, I really care for you, like you're my brother, you're my sister, you're my loved one, I really care about you, I'm really invested in your health and your well-being. So it really is about being human with them. And when I'm human with them, they're more likely, and I found that they trust me and they follow along with what I do. I think it's very important to set an example. I live and I can share my examples with them. I have bad knees. I talk to them about my knees and what I have to do to take care of my knees while I continue to exercise. So I try to be as human as possible with them, not the doctor, them not the patient. Build a rapport, and they keep coming back, and they have their wobbles. They'll message me. We have Epic as well, and they'll message me. You know, I didn't exercise for 2 weeks. I'm not sure what I should do now to restart. So I want to live with them. So it's a commitment, but you know, you couldn't pay me enough money to satisfy me. I mean, I think that goes the same for all of us. It's not a matter of money. It's what you feel inside and what you can give to each individual patient and the community that you live in. I think that's really what it comes down to for me. Thank you very much. Thank you. Oh, was it?
I just wanted to ask about diet. I'm sure that's another lecture.
Yeah. So again, listen, I think diet is so important. I married a nutritionist, so yes. Are you a nutritionist? No, yeah, okay. But diet is essential, of course, yeah, another lecture.